Good evening, Dr. Surya Prakasa sir. Hello.
Good evening,
I am Dr.
Srinivas
Srinivas.
Kumar.
I am Dr. Srinivas Kumar. I can see you and hear you,
Okay.
sir. Can you
Srinivas,
introduce your case?
please, my colleagues Kapardhi and Dr. Vishwanath, Dr. Kapil, and Dr. Narayana, everybody here with the technician Lakshmi Narayana, Bharati, Vidya, and Madhu, Prithvi. My colleague Kapil will introduce the case to you.
Kapil Japra.
Small case.
Hello everyone, good evening. Today we have a 56-year-old diabetic and hypertensive. He presented to a hospital that was in the different city with class 2 anginal symptoms. And there is an evidence of old infiolemi on ECG and echo. And he has mild LV dysfunction. In the same setup, he underwent angiogram which showed LCH and RCA, both CTOs. And RCA CTO was attended at a different center on 13th of March. And then that was abandoned and the case came to Apollo. And we have reviewed the angiogram and we have advised for staged PCI, first to LCX, then followed by RCA. So, this is LCX CTO crossed with Fielder XTA with core set support and stented on 26th of April. And after 5 weeks, today we have took him for a PTCA to RCA CTO. This it's a mid RCA CTO with an ambiguous cap and septal collaterals filling the distal RCA, and segment appears to be more than 20 mm, and it's a second track. So JCTO score is 3, and this is a cranial view demonstrating the septal collaterals. So over to the operator. Thank you.
What is the plan today, sir?
Surya Prakash, you have reached to what stage of your procedure?
Please.
Actually, because of the ASS, Dr. Srinivas Kumar, in the previous attempt, because antegradely some false human was created 2 months back, first we want to try retrograde. Can we show retrograde recorded films? Recorded films, please. Actually, the second septal collateral is adequate to fill the distal PDA. So we tried initially to enter into the second septal, and then we changed it to CO with the caravel support, and we observed some peculiar difficulty at the distal end, where because of the angulation points as well as tortuosities, we find some difficulty in navigating the wire into distal PDA from septal collateral. Please, can you show that one? Can you show the angiofilm? We are showing angiofilms.
No angio.
Both femorals, both are 7 French guides, huh?
Yes. Yes, both 7 French. Left is Ibu 7 French and right
We
is
have taken contralateral injections, bilateral in caudal views and cranial views to profile the collaterals. I know they are not that happy collaterals. Exit points are not clear. But this case having a JCTO score of 3 almost. So I have to try a retrograde first C. So we are trying to cross the second septal, which appears, show this second one. How we cross it the second septal? We cross the second septal with a Carvel catheter, then we went ahead in a selective injection, and none of the branches, there is a corkscrew, we tried with CO wire also, but at the end it's not negotiating, the deadly curve we can see. And after that we tried the first septal also. It's a difficulty entering the angulated septals, but we successfully entered, but the exit point is not clear. in this also. So there is no other option for us to go anti-grade because it is more than now 6 weeks. And there is only one view in the lateral view. I can see a distal shadow in the retrograde injection, which I am trying, and I am concentrating on this. My colleague will talk to you.
Yeah.
For sake of people sitting here, many people we don't tend to ignore right lateral view.
Yeah, yeah.
But it's a good view to see whether there is a faint antegrade
Okay.
track and how our wire is behaving. It gets outlined
Yeah.
quite better when this gets
Yeah.
studied. What is this wire you have taken?
Because this is a
This is Gaia 2.
second.
Gaia 2, because it's a very hard block, and there is no point in trying the soft wires in this case.
Yeah, generally the steppered wire approach, the people tend to take when there is feeling that
Go
there
to
is a
LAO.
faint track. Here it is total cut off, ending into a
Because
branch.
this
That's
is,
why we
you
have
know,
taken stiffer
already
wire.
it is a ambiguous cap is there, and lot of tougher things in this case.
Yeah.
There's a branch also coming there. Just
retrograde.
a collar.
Negative points actually
Okay,
here.
we are little better. Guiding సరిగా ఉందిరా చూడమ్మా వెళ్ళేవుకురా guiding.
Even in the proximal RCA, there appears to be some disease before it is totally occluded.
There's a block is there. I know. Show the distal thing. In LAO cranial, which one you want to process? Show me the LAO cranial view. Retrograde you show the injection.
Hello, cranial.
So it's a difficult situation. We don't have a good retrograde collateral. Always there's a limitation in a retry.
Hello, cranial.
That actually tomorrow my talk also there. And a retry, usually we go for retrograde these cases. Okay. So I'll push the course down. Come to LAO.
Yes.
We are monitoring the ACT also, time to time.
Your progress to some extent, it looks.
Yeah.
It looks, but you know,
Distally retrograde filling is not up to this one, up to distal cap.
it's a long segment. So one of the suggestion is from a colleague that why don't you go the
From the hard wire.
retrograde. You can, if you cross the lesion, I would like to de-escalate the wire. If I can cross the lesion, LAO చూపించవా?
Plain yellow, plain yellow.
Plain LAO only. Guiding, how is the guiding place? That's important.
Correct.
Eh?
You have to this.
Okay,
You have to adjust the tip of the position.
now it's better.
Some resistance you are getting.
So another option is take a support because I have to cross a tough lesion. I need support. The corsia not going down. So
How much pressure you are exerting for pushing this wire? So you are
not much. I know unless I know where I am. I don't want to push pressure.
and this is a unilateral clockwise
Because
rotation
retrograde
continuous,
injections not showing.
single direction.
Dr. Surya Prakash, as you keep trying,
needed, I will,
he
change.
says that we need to
Yeah.
move to SGPG lab. We'll go there for 10 minutes and come back to you. Is that okay?
Please.
Okay.
Please.
Dr. Surya Prakash, we are with you.
We'll take over.
Sir.
Please, please.
Ah,
As you know, it's a tough challenge
tough.
in my experience. This type of case, a long segment, calcium, and there's a bend, there is a retry, there's a ambiguous cap, and collaterals not good at all, exit points. And so my workhorse whites in this type are Gaia 2, which I tried, but the block is so hard. And the guiding support, the Corsair also not able to cross the lesion. So I changed to a Gaia 3. Yes, at the bend it is not the ideal wire, but little manipulation I could cross the distal bend. Hopefully I am the distal
Angiogram.
vessel. Please see this.
Show angiogram.
Show the steps.
Hey, recent. Gaya third.
Anni
Okay, show.
uddaya.
You're from the last.
Why he is
time
showing
to
again? Our
present.
technician is.
Yeah.
I know he is over enthusiastic. So in spite of my telling time sense, they don't understand.
Yeah, we left you at this stage, I think. Okay.
So at this stage, X next.
Next.
I am checking in RAO, LAO, RAO, LAO. You see, this is very important RAO view in RCA, this type of mid RCA segments. Next. 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 We are giving fluoro save mostly to, and we are using a rat pad also here to control, because when you do frequent CTOs like this, I know. Now
This
this is very
Please show.
important thing. You see the this is the view which you can make a confident approach.
Entry to the distant
That,
channel.
why, yes,
Next.
wire is an intimal plug.
Ah.
Intimal plug.
Next, exactly. Next. As I am worried about this point. Actually, if my Corsair goes down, I will de-escalate the wire to something like a filter XTR or something. But unfortunately, I have to come out. The gate support is not good. Next. Now, I crossed it, and hopefully, I will check
is
in
in the
always two oblique views, but it went into one of the distal RCA. Okay. This is a stage. Now, I cannot advance the Corsair in this case. I will use a balloon trap and take out the Corsair. 2.5 balloon.
1 mm bone dilatation. That is the plan.
Maybe it needs a 1 millimeter low profile balloon dilatation, and otherwise we have to use something like a Tornus.
Which balloon you are planning to take?
No, this is
2.5.
only a trapping balloon, 2.5
Trapping balloon.
NC. To
Trapping.
I want to pull out the Corsair.
To remove the Corsair. First,
Show the guiding. Babu guiding చూపించండి balloon.
Corsair వెనక్కి తీసుకోండి.
తీసుకుంటాను. Open it. Open it.
Opened already. That's all. కొంచెం వెనక్కి తీసుకోండి. Now you advance this bell. Fluoro.
No problem.
Now with balloon trapping, the Corsair, now we are removing the Corsair.
Okay. Okay.
Yes.
The balloon is passed
Okay.
just besides the wire, and once it is distal to the Corsair, it is
Yes.
inflated,
Ah.
and then the Corsair is taken
Yes,
back. For sake of others here, I am just repeating.
Exactly. Yeah.
Please.
Open Jason. Opened.
Open. 14? Okay.
Yeah.
Okay.
But
Okay. Deflate the balloon. Take 1 millimeter, 1.5 millimeter any balloon. Keep there. At the end, we
Yeah.
check the retrograde collaterals. At the end. ACT, please check the ACT. కొడుతున్నాను.
The disease is there. Yeah, there was also a disease, and it just proximal to the lesion there is a branch.
Branches.
Yeah, that's why he's handling, trying.
Once I get it, the segment, CTO segment, I can open. I can do many things here.
The proximal to the
CTO
CTO,
segment,
there is a branch
that's
here.
important. Yeah. I know.
Surya
I
Prakash,
know.
proximal to CTO also there is a branch.
Uh-huh.
So the suggestion that when you would like to anchor that branch.
And that
Yeah, yeah.
always we
If-
thought.
if-
Now if it is troubling me, I will do that.
If this balloon
This
won't
2
go, then
millimeter,
definitely anchor balloon is the
1 point.
next try.
Okay.
Cheppandi agade. 2 marker,
Just come, single mark.
you.
Yeah. Very good.
Okay.
Now it is going.
Dilate it here.
Now you see the progression of the balloon.
It went in easily, it looks.
10, 14. No. It is at
With-
the
with-
CTO segment.
CTO, so a little bit
It is at
resistance
the
is going.
CTO segment.
It's better
Part
to
of the
go,
balloon just entered. That's why. No.
Yeah, it's better to
It
go
is
as much
1
No, it
millimeter
went.
balloon.
It is
will
going.
go, 10.
It's going slowly.
It is a
Yeah.
1 millimeter balloon. Okay.
Now it crossed the CTO segment also.
10.
Yeah. Yeah.
See it. Lot of resistance, but we are able to. Do it. Do it.
It's also.
Chain end. This is 10. Okay. Now take a 2 millimeter balloon.
అయితే కోర్సెస్ ఎక్స్చేంజ్ చేసుకుంటారా
అప్పుడే కాదు వద్దు 2 చేసి 2 చేస్తాం. ACT please.
నో నెక్స్ట్
Huh?
248 2500 ప్లీజ్ గివ్ ద రన్నింగ్
Two millimeter balloon. So Srinivas Kumar, what are your suggestions? Suppose if I fail to cross wire cross with Corsair support,
ఇవ్వండి 25
with the whatever wires you are used to work, mostly Gaia. Suppose what are the other options in this case? There is no retrograde choice because the very nasty exit points.
ADR.
I tested everything, only 2 collaterals are there. So what are the other options? You can have a discussion.
But here now you have crossed the
ADR is
balloon. I
another
think
option.
You are taking upsizing the bigger
No,
balloon
no.
and then inflating.
Suppose I know.
yes same
I know, but I'm just for discussion. In this
Okay.
situation where the retrograde option is closed, and if I find my whatever wires in the subintima, because it's a nasty lesion with a long segment and so many issues. So what are the other
Yeah.
options people should have, either to close the case, go for a ADR?
You want to comment? They are requesting us to move to other lab, sir. For last time, I think we'll just go to
Please.
PGI and then come back to you.
Please.
Yeah, Dr. Surya Prakash, we are with you again.
Please. So we you have at that stage show that with a balloon anchoring the trapping balloon, we exchange it to the Corsair.
You put 2 wires
PM
now it
with a
looks.
soft cyan wire
Next.
floppy.
next yeah
Now because
PD also they put
next,
on the-
next. Now
We have
after
seen all
this,
this. Balloon dilatation also we
I know. Next. After 2 millimeter balloon dilatation,
Yes.
I could pass the course. Next. 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 Now we exchange it with a cyan wire. Next. Next. Now this is the picture. You see there is a, as you said, the proximal plaque, mid CTO segment, and there is a distal plaque, and there is a PD, large size PD. That's why I have to wire it. So I have to do a 2.5 balloon dilatation because the plaque very harsh. Wait.
Did you do
Very
the
hard
IVAS
blocks,
examination?
So
Now I don't think there's a
I
requirement
will
of
do
left guide
a
now. We can
balloon
remove
now.
that left.
We'll remove, no, important thing is I will give
Collateral.
an injection, see the
Collateral.
collaterals, then only I'll remove. That's important.
Now you're seeing, no, the distal vessel has filled well with this antigrade.
No. For the collateral injury,
Collateral injury, minor injury
anything
happened.
without our
Okay.
notice, because we tried the collaterals. That's important.
Small test him. Test.
So, okay. No, it's a very, very hard plaque. Now you give. No,
Yeah.
no,
I
no.
think there is a
You
small
just dilate. No.
segment before the bifurcation we need to have, because again, they extend it again,
Yeah.
one of its
Yeah,
oh,
yeah.
it gone
Yes.
behind.
Please.
Then come back and inflate more, just
Please.
before bifurcation.
Here we are doing. Please do.
Yeah.
Do. Please do. 7, 8, 9, 10. It's a very
12.
hard plug. 12. Okay. And dilate here also. 10, 12. For a better stent deployment is good. You dilate. 12, 14. Okay. Because he needs a long metal jacket, I can understand the way the lesions, instead of putting small short stents. Do it here. Put it. Okay. Then you do it
Yeah,
here.
there is a lesion again there.
Okay. So give the same stent now.
Can give some nitro.
Yes, we can do a. This reasonably good sized vessel. I don't think nitro is needed for this.
Before you select the stent size,
So
I think
we
it's
have
better to inject
taken,
nitro and take picture.
To
Then RCS are
do
notorious to grow.
to do IVAS to do IVAS is ideal.
Yeah, that also
But,
is okay.
okay. So you
2.7.
you give this. We already opened a stent. I thought it is around 2.75. So which we could not
38.
negotiate. That's why I have to balloon dilate.
Distal extent, I think you should end just proximal to the bifurcation.
Exactly.
part?
Anyway, we after balloon dilatation we did not give an injection. We'll see. Then only we'll decide.
Yeah.
It's
Now
good
you can
only
use
now. It looks good now.
Distal it has opened up quite well actually.
Oh, good.
Okay. What the maximum? This is Promus. This is
Elite. Promos elite.
Promus elite stent with Promus
7.5 to 38.
regulating balloon, and nominal is around 11, and at burst pressure of what is the size? 22. How much it can expand?
I was told that this has a high pressure taking balloon inside with the dual layers of the balloon, so that it will extend up to a
Layers.
very high
Yeah,
pressure.
yeah.
Now you can give small pocket. I will keep like that.
Yeah.
Okay,
Yeah.
do it. One wire we can remove, PDA wire. PDA wire we can remove.
See Angana?
This is a PDA wire.
Right,
Okay.
ante, same.
Now we can give small puff. Okay. I don't
That's all.
jail the PD. Okay, do
Yes,
it.
sufficient. Now you can cover.
12.
Stopping short of this tent is just before the bifurcation.
Yeah.
This you can measure with
I
the
can
same.
measure. The same balloon I can measure. I have to cover the steam also. This is
That was what,
this
28?
small. This is
38.
38.
First one is 38.
So go to a caudal view. Go to a caudal view. No, come to RO caudal. RO caudal or AP caudal. No, go to that side. Keep like that. Keep. I'll pull the guiding out. Then we'll see how much. Small puff system.
No, too much full.
Be careful, be careful. Guide has come out.
No
right.
problem.
Yeah.
No problem. No
Yeah,
problem.
yeah.
No
Yeah.
problem.
I think the size is okay.
Small puff.
It is fitting correctly only.
Sufficient.
Uh,
Exact.
Okay. Take another 3 into
38.
38.
38.
Take, Take a 3 NC balloon.
At what stage will you remove the second guide? You are not planning. Surya Prakash?
Okay, we'll give an injection and remove. Okay.
Just we test the septal collateral
Okay,
and
come to epicranial view. Come to epicranial. Show the collaterals, please. I want to see the left main and collateral. RO cranial, please. Yes. Okay. A small channel that's usually heals. Nothing to worry about that. Usually.
staining was there. That's all. We can remove.
Yeah.
Okay. Come to the LAO.
No.
You can advance the wire a little.
Right. And alignment is important here.
Yes.
If you
Now
have
it is aligned.
alignment,
Now it is aligned.
it will go.
Yeah.
See the stand
Overlap you
boost
can see.
once. Can you do a stand boost here? Convert to no?
Just go more.
More, furthermore. You have to move. Go further. Yeah, you have to go further. Right.
Do a stand boost.
Little
once.
more.
Plain sini we can. Plain sini we have to do. Then stand boost.
Extend boost. It went.
Still more,
Slightly
there's a
out to
gap.
go front. Yeah. Villal. Yes.
I think it went.
No, you can do
Open
stent
up.
boost.
Please open up. Please open.
No, you
It
have to
went
do
deep
stent boost.
actually.
No, stent
No,
boost
no,
you
no.
did, sir.
It is went
Touching.
very deep.
Full, sir. Nothing, not deep. Just
It
touching,
is,
sir. Stent boost you can take. Now,
more than just overlap is enough.
yeah,
Okay.
not touching, sir. Just. No, bah.
This fellow
Please, you can.
can never show.
No, even proximally RCA,
It's
osteum was
okay.
okay. Just after the osteum there was receive.
I will
Osteum
check
is
that.
okay.
No. I'm checking. I'm checking it everything before deployment.
If osteum is okay, then
please
probably
give
we
small
can leave
puff
that and
sister.
put the stent properly distally.
No.
Still
I will
not,
put the
not
osteum
covered.
coverage
Still not covered.
because then only the result will be perfect. Because
You want to cover, you're saying?
Not covered. Yeah, you have to-
exactly.
No, not covered. Osteum ఉంది సార్ ఇంకా ముందుకు వెళ్ళాలి ఇంకా స్టిల్ నాట్ కవర్డ్ not covered actually, it is not
No,
covered.
I have to cover. What I am
That's why
telling
third
this
stent
to-
you have to take.
This is we have to
No
take a third
overlap.
stent. Yes,
Still you have to go down.
That's why. Now it is overlap. Now small puffy.
Small test here. Now it
Okay,
is
no,
covered.
Do it now.
It's actually more.
Yeah.
You can come back a minute. You can change the stent, I think, take a longer stent.
That is
38,
longest actually, 38. In that. బాగుంది కరెక్ట్ చేయండి సార్ అంతకన్నా ఇంకా
Okay, do it. नहीं. 1240. Okay.
Osteal disease, unless you are
Just
forced to
to-
cover, it is better if it is not there, or your policy is you cover osteum throughout in Japan. How do you do that? You have, suppose borderline disease in osteum,
Three
50%
balloon
disease.
this one.
Would you like to cover with the stent or
Three
leave
NCP.
it?
But in terms of the RC osteum, late result is not so good. So if the stenosis is around 50%, I would like to leave it.
Stent visible.
Because osteal restenosis will
Good,
be
తీసుకో,
higher,
మూడు.
however
Yeah.
best,
కానీ బాగా
unless you are
ఒకసారి
forced to
ఇది తీసుకో.
cover,
Caudal
Caudal
view
better
అవ్వ-
to avoid.
కాడల్ వి బెటర్
అటు కనపడదయ్యా అటు వెళ్తావు నువ్వు
బాగానే ఉంది సార్
వెళ్ళి ఒక clinic వెళ్ళి.
ఆస్ట్రియం ఈజ్ గుడ్ యాక్చువల్లీ
లేదు కవర్ చేయాలి
అంటే ఇట్ కవర్డ్ ఎంటైర్
టేక్ ఏ
ఆస్ట్రియం బాగానే ఉంది
వాట్ యు
I think there is
ఫీల్
reflux also
విల్ డు
coming.
ఐవస్ అండ్ చెక్
ఎస్ ఆస్ట్రియం ఈజ్ నాన్
విల్
డిసీజ్
చెక్ ఐవస్ అండ్ సీ
We can check also first view how it was.
Take
Osteum was free from
three
disease.
visits.
The tight disease was there after the osteum.
ఎస్ ఎగ్జాక్ట్లీ డజంట్ రికవర్ యా
All you
Do
want,
I
you can
was-
take little, that proximal portion where the tight lesion was there looks slightly under. After the imaging, then you can take little high pressure balloon and do a NC balloon dilatations throughout once, to a long stent.
దిస్ వన్ వీ కెన్ టేక్ తీసేయండి అది అదే నేను తీస్తుంది ఎందుకు కాదనుకున్నాను ఓకే ఓకే
We'll go there.
ఓవర్లాప్ ఏరియా This is overlap.
ఓవర్లాప్ సెగ్మెంట్ ది సేమ్ సెగ్మెంట్
It's overlap I am doing.
What size balloon is it?
14, 18. This is 3.
3
Same na? Do it again. 18. Okay. Save. Do it here. 14, 16. Remove. Do it here. 18. Okay. Do it here. 16. Okay. So give a IVAS now, please.
Okay. Bubbles in the mouth. Flush chair. Flush chain.
Flush.
Flushing. Flushing.
So what is the ACT now? 370 తర్వాత
ఎంతమ్మా?
273.
273 తర్వాత
Then you have
మళ్ళీ
given to
పడింది.
5. Before leaving, check it again.
ఒక్కసారి చేయండి చేస్తే
I was తీసుకుని we'll see osteum also.
అంతే.
Give the IVAS. LAOకి రా బాబు.
As you keep doing IVA, sir, we'll go to the other lab and then come back to you in another 5 minutes or 10 minutes.
Okay.
Okay?
Okay.
Sure.
Sir, we are with you live now. Last few minutes
Please
of
go to the
transmission
IVAS.
left.
Please,
Surya Prakasa-
please go to the IVAS, sir.
Ah.
I
Show
was.
the IVAS picture. Yeah.
I was.
Change sister. Change.
I was. Babu.
10, 14, 16, 18. Please.
Actually, I was showing some under expansion both distally as well in the proximal segment also. So we take 3 mm post and balloon and dilate it distally up to 16 atmospheres.
Send boost.
And then
Okay.
proximally 3.5 mm balloon we have taken, and we are doing proximal optimization also.
Paddle.
Yeah,
Up
after
to
seeing
16
that angiogram
atmospheres.
picture, I mentioned the same before. It looked like even in the
Yes,
angio,
yes.
it looked slightly less.
Less, yes, exactly.
Okay.
Now we are doing
Only at the-
proximal thing with 3.5 mm balloon.
Only at the osteum, I think we need
And
to be
distally already it
careful.
was done.
Yeah, proximally
Yes,
you need to be
exactly.
careful to be within the stent, because if you dilate it to 3.5, there's already a mild disease at the
Yeah,
osteum.
We
yeah.
have done a
We-
stent
we-
boost. We have done a stent boost for that.
We are taking the same
Okay.
precautions actually, Srinivas Kumar.
Over
Yeah.
dilate. Yeah.
Just 12 atmospheres.
12 Kelvin.
12
8,
atmospheres.
9, 10, 12.
Ciao.
This.
Sufficient. Now we are taking checking last final injection.
Yeah.
Yes. Yes. Okay. Cine this అయిపోతుంది కదా. Cine we can.
Put a leocranial.
Cine. Yes. This is the final cine.
Yeah.
Okay. Are you
Looks good,
satisfied with the result?
Yeah, congratulations for excellent demonstration. And we
Okay.
close your session here, and then we go on to PJ.
Thank you, Srinivas Kumar and all your chairpersons there for the excellent discussion and helping us in right times. Okay.
Thank you.
Thank you.
One minute.